So welcome everybody, and thank you so much for taking the time out of your busy day to attend today's launch. My name's Lisa Cox and I'm the Patient Engagement Lead for the Thames Valley Cancer Alliance. We're recording this session today to enable us to share it with those patients who haven't been able to attend, but who would still like to learn more about the work of the Alliance and what activities we're currently underway with. Today's launch is an opportunity to bring together anyone affected by cancer, all those working to support communities across the Thames Valley. It's an opportunity to collectively meet the wider team members and to hear about our programme of work, as I've mentioned, and how we're keen to ensure that the local community voice is incorporated to help influence change and improve the cancer services within the Thames Valley. I'm thrilled that we have so many people from various different representations from our local trusts, charity partners, voluntary and community sector organisations, some of which are new partners to us today. Next slide, please, Nat. So before we start the main content of the meeting, just a few housekeeping points. Appreciating that there's quite a number of us on the call, it'd be useful if you could please use the chat function to share with others your name, the role that you hold, and the organisation that you're representing if appropriate. It would be good if you could please use the chat function for comments and/or questions throughout the meeting, as we want to obviously make this as interactive session as possible, and we'll review this during the question and answer session later. To help reduce the background noise, it'd be greatly appreciated if you could please mute yourself during the presentation until this question and answer session. You'll then obviously be given the opportunity to either continue to type your questions in the chat function or to visually raise your hand to be drawn into the conversation. When presenting, it would be really appreciated if our speakers could turn their cameras on and speak slowly and clearly for the benefit of everyone on the call. Next slide, please, Nat. So we have a packed agenda today, as you can see, and we will endeavour to hopefully finish promptly at 3:30. Today's agenda includes giving an introduction to the Alliance and work that we're leading, as well as hearing from some of our patient representatives regarding their involvement to date. We'd also like to highlight the purpose for this patient partnership forward, as well as there being an opportunity for you to ask questions to members of our team. I'd now like to hand over to Victoria, our Head of Service Improvement, to introduce who we are as an alliance and who we work with.
Hi, Lisa. Unfortunately, Victoria has been called away, so I will do this session now.
Oh, okay, Abby, thank you.
It's unavoidable, unfortunately. Hello, everyone. My name is Habi Odubayo, and I'm the acting head of programs for the Thames Valley Cancer Alliance. So Ruth sends her apologies. That's Ruth Wilcoxon, our managing director. She couldn't be here today, but she sends her very warm greetings. In her absence, and now in Victoria's absence, I'll just run through a couple of slides on who we are as an alliance. I'm sure quite a few people on the call today already know about the alliance, but just for the benefits of those who don't, we're doing this brief overview. Could you please let me know if I start to break and I may have to turn off my camera? Just let me know. So just to do a quick intro about the Alliance, the Thames Valley Cancer Alliance was established in 2016, and this was following the publication of the National Cancer Task Force Strategy, World-Class Cancer Outcomes, and that's a strategy for England. And within that strategy, there were 93 recommendations. And one of those recommendations was actually the establishment of cancer alliances, and the Cancer Alliance was born out of that. As an alliance, what do? We bring together multiple stakeholders to take a whole population pathway view of cancer services across Thames Valley. In essence, the Alliance can be seen as a local vehicle for collaboration and partnership of stakeholders to drive the implementation of the NHS national cancer ambitions. So as an Alliance, we provide cancer-specific leadership for the integrated care systems. We work in partnership with various stakeholders, and the aim is to secure and deliver the best outcomes for every patient affected by cancer. Our mission is simply about saving lives, reducing incidence through raising awareness on the signs and symptoms of cancer, and promoting healthy lifestyles. improving the treatment and survival through looking at the care support patients should expect across the entire cancer pathway, reducing variation and supporting the implementation of best practices. In terms of our coverage, the Thames Valley Cancer Alliance covers the Thames Valley patch. This is in the main localities of Berkshire, Oxfordshire, and Buckinghamshire. We are also closely linked with neighboring hospitals and trusts from Swindon, although Swindon sits with another alliance, the SWAG, but we do work closely with Swindon. And also Milton Keynes, even though Milton Keynes is situated in the east of England, but we're linking closely with them. I think this is really because Oxford is a tertiary institution. Next slide, please. In terms of who we work with, on the slide you have a few lists of the organizations that we work with. So we enable, the Alliance enables network of organizations linking clinicians and managers locally, regionally and nationally, which has a vital role in fostering the clinical vision and to help develop a sense of belonging and commitment. By working with people like yourselves on the call today who use and care about NHS services, we can better understand the needs of our patients. This in turn will help us to improve access to services, patient safety, patient experience, and everyone's health, especially those who we know experience health inequalities. And by working closely with our key stakeholders, we enable the sharing of experiences of cancer and the services provided during care. And this is invaluable in helping us to shape future treatment pathways. Next slide, please. As an alliance, we worked closely together with our key stakeholders, and we identified 4 key priorities for 21-22. And these are on the screen. Sustainable operational performance. This is really about working with the systems we trust to ensure that that we can actually manage our backlogs, especially as a result of COVID and the impact of COVID. It's actually working with the trust to see how we can get back on track. Implementation of a pan-alliance ITT working group to support policy creation. We also have the rapid diagnostic services. In the course of the meeting, you'll be hearing more about some of these services, as well as addressing one of our other priorities is addressing shortfall in treatment from 2021. Again, this is as a result of the impact of COVID, where there's been a drop in the numbers of patients that have been treated. And so one of our key priorities is to actually address this shortfall and come back to our pre-COVID levels. Another of our priorities is a personalized care agenda, which is really about making sure that patients receive the right care in their journey through the cancer pathway during treatment and beyond treatment. And I think that's it in brief, Lisa, and I'll hand over to you again. Thank you.
Abby, thank you so much. Thank you for standing in for sort of Victoria and Ruth at last minute. That was great. I really appreciate the content that you've shared. So I'd like to hand over now to our workstream leads. Mark, if you're happy to lead on the quality improvement scheme.
Yeah,
absolutely. Thanks, Lisa. So just to confirm, the quality improvement scheme has been running for the last 3 years across the Thames Valley area. The aim of the scheme is to increase screening uptake on the 3 national cancer screening programs, which are bowel, breast and cervical, but also to ensure that patients are diagnosed through the correct route. So, for example, the 2-week wait referral, if that's appropriate. So the Alliance created a toolkit to help primary care networks and GP practices deliver the scheme. The toolkit is for primary care teams, both clinical and non-clinical, and it's to make information easily accessible within their practice. So clicking on each coloured section heading takes them through to the relevant place in the toolkit. So for example, you can see on the slides some of the heading examples such as patient information and awareness campaigns. So that's just a really quick overview of the quality improvement scheme. So I'll now hand over to Nana to talk about some of our innovation projects.
Hello.
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 Afternoon all. I'm the Early Diagnosis and Program Manager here for Innovation here at TVCA. I'm just going to quickly run through our exciting innovation pilots. Thanks, Mark. So the innovation program was set up to speed up the path from innovation to business as usual, in terms of spreading proven new techniques and technologies. So the aims of the program was to enable testing and evaluation of prioritized innovations in a real world setting, and also to accelerate rollout of prioritized innovations. Moving forward and beyond, we are looking onwards for the national program in terms of input and analysis. We have a rollout for patients' needs that we also want to be able to bring in patient voice into national discussions. So sessions such as these has been really helpful moving forward as well. We also had an impact assessment questionnaire, which was mainly within the NHS England and their cancer team, and they asked specific questions around patient engagement, just really to determine what level of involvement there was with patients during development, testing, and evaluation of innovations. So I'm just going to run through quickly 4 of the innovation projects: targeted lung health checks, colon capsule, endoscopy, cytosponge, and Grail. Yeah, next slide, please. So we have here first the target lung health check. You able to run the video? Fantastic.
Health checks are a simple checkup for people aged 55 to 74 and who have ever smoked to find out how well your lungs are working. Think of it as an MOT for your lungs. We get our cars checked every year to make sure everything is okay. Our lungs work hard every minute of our lives, so it makes sense to do the same for ourselves, especially at the minute. Most people who have an appointment feel very reassured. You'll have a virtual appointment with a nurse, either over the phone or a video consultation. The nurse will ask you some questions about your breathing and about your overall lung health. The appointment will take between 30 to 45 minutes. During this time, you can also get the chance to ask any questions and also talk about the ways you can improve your overall lung health. If you are still smoking and would like some advice about quitting, the nurse can help with that too. They may also talk to you about having a lung scan to check for any early signs of lung cancer. This is very common and is no cause for concern. If you are invited for a scan, it is done in either a mobile scanning unit in your local area or a local hospital. A CT scan is a type of X-ray, but it involves more radiation than a standard chest X-ray and shows more detailed pictures. It is used to check for any signs of lung cancer and lung disease. The scan takes around 5 to 10 minutes. There is no need to prepare in any way, such as fast or have any injections. Some people feel a little uneasy about having a CT scan, but it is a quick and painless procedure. You don't have to have the scan if you don't want to. However, if you do have lung cancer, the earlier it is caught, the better. If it's caught early, it can be cured, and someone who knows firsthand about this is Joe. Joe was diagnosed with lung cancer after attending a lung health check at the end of 2019. It came as a huge shock as Joe had no symptoms, is very active, and hadn't smoked since she was a teenager. Fortunately, it had been caught early and Joe was able to have surgery.
I definitely did not realise that it is something, you could have surgery for and walk away. Yeah, that's just never crossed my mind. It's when the consultant I was speaking to used that word curative that I first thought, oh, you know what, you might just be cured. I do actually know of people who have not followed up on the invitation. Once I was talking to people about my experience, they've maybe said, oh, I think I got a letter. And I suppose it's, it's understandable you don't want to go there. You don't think that it really has anything to do with you. You know, it's just a very general check of the population. But my experience says, well, you don't know what you don't know. There's an onus on us to do our bit, you know. And if we're being told that you know, it would be a good thing to have a checkup, then have it. And if you value your health, why wouldn't you have it checked?
As Joe's experience shows, your lungs could be easier to fix than you think. If there is a problem in one part of your lung, treatment can focus just on the bit that is affected. The key is to get the problem early. If you are eligible, you will receive a letter from the NHS inviting you to a lung health check. You are invited whether you feel fine or not. If you have not received a letter, are unsure if you are eligible, or have any concerns about attending, please contact your GP.
Fantastic, thanks, Lisa. So on the other innovation pilot we have is the colon capsule endoscopy, or for short CCE. With this one, we actually was a national innovation pilot, and I've just broken it down into 3 stages just to make it quite simple, just to grasp it. Swallow the capsule, the patient will swallow the capsule, and there's a camera that travels into the colon, and you can wear a wireless belt underneath the clothes. It's no bigger than a pill, so it's quite a small capsule, and it can provide a diagnosis within hours. So we had an initial group of 11,000 NHS patients in England, and they will receive the capsule cameras in more than 40 parts of the country. So that's great. Next slide, please. Moving on to the cytosponge. Again, I broke it down into 3 stages just to see how it actually happens. And I've also listed who is also endorsed by on the right, so we can see. With the cytosponge, it's also a capsule, but it's holding onto a string. It's quick, safe, and inaccurate tests that can be performed in regular GP surgeries in 3 simple steps, which I've listed here. So you swallow the tablet, swallow the capsule, and removing the string from the retrieval, it will collect and process the cells. It takes about 1 to 2 seconds. Thanks, Lisa. On to the next slide. We then have the Grail, and this is with the blood test, which is developed by Grail and is innovative and is actually world-leading program within the NHS, and it can actually spot more than 50 types of cancer. One of the chosen centres that we're using at the moment is within Oxford, within the Thames Valley region. We have over 6,000 participants and enrolled over 3 months at NHS hospitals in England and in Wales. So that's the pilots. I'm just going to move over quickly onto the campaigns. Thanks, Lisa. So I don't know if many of you have been able to see, is we'll be doing the Help Us to Help You campaigns. It was actually launched on 16th August, and we'll be running the 2 campaigns, which will be prostate and lung cancer. So with the prostate, it'll be abdominal and urological, and will also be, as I said, the lung cancer campaign. We'll be running ours from September till the end of the year. And the national campaign, as I said, has started to roll out, and that'll be to the beginning of November. Obviously, as we're aware, it's a different year this year with the different winter pressures and with COVID. However, we do want to be able to continue to raise the awareness of cancer systems and just have the reassurance of the services that are out there at the moment and be working with patients as well at this time. So that's all from me, Lisa. I'll move over to Hannah. Thank you.
Hi everyone, Hannah Hollis here. I am the lead for personalised care at Thames Valley Cancer Alliance. So the personalised care programme of work really has 3 key elements. And the idea behind personalised care is that we look to support someone's, the holistic side of somebody's journey as they are first diagnosed, through treatment and beyond. So the 3 key elements that we've got, the first one is personalised care and support planning. So this will include elements such as holistic needs assessments that are completed by the nursing, or typically by the nursing teams within the hospitals. Also reviews called cancer care reviews that are done by the primary care teams, and ensuring that patients have access to health and well-being support, again, once diagnosed, throughout treatment and beyond. The second element of personalised care is what's called stratified follow-up. So this is once a patient has finished active treatment, we often surveillance patients for a number of years afterwards. And those of you that obviously have had your own diagnosis, or a loved one with it, will know that often this is kind of a 2 to 5 year process where we'll have regular scans or tests that are done to ensure that if the disease doesn't reoccur. Stratified follow-up looks at the best way that this can happen for patients. So historically, that's been the tests and investigations being done in the hospital and patients returning back to the hospital to find out those results. But actually what stratified follow-up does is allows patients to manage their condition themselves whilst still having the tests and investigations, and also getting those results to patients in a more timely manner to hopefully reduce some of the anxiety that comes around with that as well. And a key part of stratified follow-up is patients ensuring that they really understand any kind of red flag signs or symptoms that they should be looking out for, and also have a key contact back into the trust should they need to contact somebody within their secondary care team. And the last element is quality of life, which obviously is hugely important. And some of you may be aware that there is a national survey that's being run at the moment for certain select cohort of patients who are 18 months after their diagnosis, looking at what their quality of life is like, and obviously comparative to patients within the NHS who perhaps haven't had a cancer diagnosis but have been diagnosed with another condition of sorts. And so the personalised care programme, we work with all of our partners across the patch that Abby mentioned right at the beginning of the presentation, and support the teams in the hospitals and the GP practices to deliver these elements and ensure that patients are eligible and have received all the support that they need. The way that we do this is one of our key things that we do is we hold a monthly forum where we get each representatives from each trust and each CCG and GP practice to come along and share best practice, share challenges that are happening within their team. And we do have a patient representative, and I think David is on the call. I've seen him on the list. So we already have a patient representative who sits on that group and feeds in. And the last thing that I just wanted to tell you about quickly is a new service which the Alliance is currently setting up, a new project, which is virtual health and wellbeing offer. So some of you may be aware that unfortunately due to COVID, a lot of the health and wellbeing events that were happening at hospital trusts had to be paused. And they are now restarting, but one of our hospitals in particular, which was the Royal Berkshire in Reading, changed their method of delivery and started offering virtual sessions. And these have gone down an absolute storm with patients. We've heard that they've been really fantastic sessions. And so we've actually looked to expand what the Royal Berkshire are doing and offer this as a Thames Valley wide service. The Royal Berkshire will continue to deliver their own sessions for their local population, but we'll also be having a project that spans the whole of Thames Valley, so any patients from the Thames Valley region will be eligible to come to our sessions. And David is very kindly supporting us from the patient element on that side of things as well. We hope to have communications going out about those sessions in the next month or so, so just something for you to watch out on those ones. Thank you. I think I'm handing over to Gaynor now.
Thank you, Hannah. Hello, everyone. My name's Gaynor Chart. I'm RDS Implementation Programme Manager at Thames Valley Cancer Alliance. So just to give a little bit of information, rapid diagnostic centres are based on a Danish cancer model, which were created to improve cancer survival rates. And from there, pilots were launched in the UK based on the findings of that model, working to improve cancer outcomes. The commitment to roll out RDCs forms an important part of the NHS strategy around delivering faster and early diagnosis and improving patient experience. The service offers a single point of access to a diagnostic pathway for all patients with symptoms that could indicate cancer, but where these symptoms do not clearly meet the standards required for a 2-week wait referral from the GP. But the GP feels that those symptoms do require an urgent review, and the aim is to ensure that patients will be diagnosed or have cancer ruled out within 28 days of that referral. RDS pathways for patients with non-site specific symptoms were launched in 2019 following the referenced earlier pilots, and this offered a diagnostic route for patients with symptoms of concern with no clear origin, for example, weight loss that was unexpected, and approximately 1,000 patients have travelled through the pathway in Thames Valley over the last year. And we are now working with our providers to launch site-specific pathways, initially lung and colorectal, as these are the most challenged pathways in meeting that 28-day diagnosis standard. NHS England and NHS Improvement have created an educational video showcasing the programme, and this is linked on this slide, and I believe the slide pack obviously will be shared, and I've seen that somebody has asked for the slide pack to be shared, so it will be available. And due to time constraints, we won't play that now as part of the meeting. It's only about 5 or 6 minutes, and we would encourage everyone just to give it a watch because it is a really helpful video. Next slide, please. Thank you. So this slide demonstrates the 7 key principles that are part of the implementation spec for the RDC and should be covered. So each of the components and overarching objectives of the RDC should apply to all patients eligible to be referred in. Patients should have a similar diagnostic experience regardless of where they go in the country to receive that equity of care. Now, you may hear a reference, and I think I've probably done that in this presentation here. We're talking about Rapid Diagnostic Service or Rapid Diagnostic Centre, RDS, RDC. And just to clarify, the national documentation from NHS England, NHSI, refers to the delivery of a Rapid Diagnostic Centre programme as part of the NHS long-term plan. So the RDC, or our Rapid Diagnostic Centre, for example, will be based within a region. So I'll give you an example of an RDC that's hosted by Guy's and St Thomas's, and that provides care across the whole of South East London and receives referrals from that whole region. An RDS, Rapid Diagnostic Service, referenced a pathway that would sit within a hospital. So I referenced their GSTT, for example. They've published some data and they've seen over 4,000 patients since 2016. And the data they've seen shows that it delivers a cancer conversion rate of 8% with an average time of diagnosis of 21 days. So initial analysis finds that 40% of those cancers are diagnosed at that much earlier stage of stages 1 or 2. And the RDC has also worked to detect non-cancerous diseases in 30% of referrals. So engagement with patients and the public alongside GPs and hospital teams is essential to ensure that services are responsive to the needs of people affected by cancer and the people who provide the support through that cancer journey. And it is essential that the programme works in partnership with users to transform cancer services and patient care across Thames Valley. Point 7 here, including one of the components, references the patient support. And part of the work that we're doing is around the development of a patient portal, which will provide a 2-way communication tool for patients and a trust-based patient navigator as they travel through the RDS. This will provide access to information around the pathway, access to trust documentation and what people can expect through that pathway journey and their diagnostic procedures. A prototype of that portal is in development, and patient involvement and engagement in that piece of work will be absolutely key, and we would welcome anybody interested in seeing a demo of the portal and providing some feedback to express some interest. And I will share an email address in the chat function here, and we would welcome anybody's input in that. That would be really helpful. And I'm now going to hand over to Nadia Smith, who's going to be talking about the Data Hub.
Thanks, Gaynor. Afternoon, everyone. My name is Nadia Smith. I am the analyst and data lead here at TVCA. I'm just going to briefly talk to you about the use of data here within the Alliance. So one of our largest sources of data and one of the large projects that the Alliance has undertaken this year has been the TVCA Data Hub. And the Data Hub is a data feed or a dashboard from trusts across TVCA, which reports on key cancer indicators. And it was created to improve the use and reporting of data across the Alliance. On screen, just some examples of what we use that for currently. So it enables faster reporting on the data than what's available and published nationally. It allows reporting on areas that aren't currently captured by national data collections, as we're able to determine what the key issues are for our Alliance and build the analysis around that. It also allows the Alliance to see and predict issues and work with trusts to resolve them. So what we currently get is a weekly report from the trust, which gives us kind of a static position end of the week on various indicators, but we're currently undergoing an automation project. So soon it will be a live direct feed to trusts, which will really improve the analysis that we're able to do. Next slide, please. Thank you. So just on screen is just an example of some of the typical pieces of analysis that we do within the Alliance. So what we've got on screen is a drop in referrals that we saw across TVCA during the pandemic. And what we've got on screen is drawn from the nationally published data, which is 2 months in arrears because of the validation that it has to go through. The TVCA Data Hub actually has data up to last week, which is an example of how the TVCA allows for better reporting. So what we can see here, each line is a different trust within the Alliance, and we can see that the trusts had a fairly similar experience during COVID, all had that kind of dramatic drop in overall referrals seen. And it's taken some time to kind of return to those expected levels. And we can see there were 9,755 fewer referrals across all tumour sites from April 2020 to March 2021, which means that there has been and still is a deficit of people coming forward for these to present their cancer systems to GPs. So this is the kind of information that we use to inform decision making within the Alliance during COVID and into recovery. Oh, can someone just go on mute? Thank you. Next slide, please. So examples of how data from the Data Hub and from additional submissions from trusts is used includes what's on the screen. So we have monthly backlog review meetings with each of the trusts that support the COVID recovery. We use data to support the TVCA priorities, such as the rapid diagnostic services, which Gaynor just spoke about. We have monthly improvement steering groups with representatives across the trusts using the data from the dashboards to discuss and escalate issues. And we also use it to support and monitor the implementation of new nationally mandated standards. For example, we're currently monitoring the new 28-day faster diagnosis standard, which is a new standard implemented this year to speed up diagnosis and improve patient experience. That's it to me. Thank you. I'll hand over to Abby to talk about Cancer Allies.
Thank you, Nadia. Hi again, everyone. So over the next few minutes, I'll quickly provide an overview of the Cancer Allies program. So the Thames Valley Cancer Alliance has developed the Cancer Allies program, which is to support raising awareness of the signs and symptoms of cancer, with a particular focus on addressing health inequalities across the Black, Asian, and minority ethnic groups, as well as people with learning difficulties and the health inclusion groups. Now, the health inclusion groups are groups that are typically traditionally excluded groups, and this include asylum seekers and refugees, gypsies and travelers, vulnerable homeless people, as well as sex workers. So the drivers for the Cancer Allies program is really a recognition that addressing health inequalities has been a challenge for a considerable length of time. And obviously I think COVID-19 really just exacerbated, that challenge. And also within the long-term plan, which is the 10-year ambition of the NHS, the ambition is that funding will be based on a more accurate assessment of health inequalities, and this requires systems to set out specific measurable goals and mechanism for narrowing health inequalities. And nationally, there's an urgent need to mitigate any further inequalities exacerbated by COVID-19. We see from the presentation that Nadia gave just now, we saw that there was a sharp decline in referrals. There was low uptake of screening programs, especially last year with the COVID-19. In terms of the key aims of the Cancer Allies program, we know that a better understanding of population health needs will help outline the health barriers faced by different populations, and there's evidence that systematically reducing health inequalities will lead to better patient experience and outcomes. And also, we know that it's important to target resources for those with the greatest need, as this increases the opportunities for prevention and earlier diagnosis of cancer, and also supports raising awareness of the signs and symptoms as well as the risk factors. So the aim of the Cancer Allies is really to work with key stakeholders, to tackle health inequalities. Next slide, please. In terms of the key focus of the Cancer Allies, so the Cancer Allies program is a rolling program of work, but our key initial focus is, like I said earlier, we want to work with communities within the Black, Asian, and ethnic minority groups, as well as health inclusion groups. So at the start of the year, using a robust data analysis, we identified the areas with poorer health outcomes, as well as the communities that we really needed to focus on. And we had a launch event in February this year, and we had a subsequent meeting in March. And we've also now met with several communities and charities, organizations, and key leaders. And in the meetings, we identified the key challenges, the key drivers to poor health outcomes. And that's what we have there: language and literacy, cultural differences, lack of awareness about services, as well as accessibility. A key example that I'll just mention here is the language and literacy. We know that traditionally we would translate resources about cancer services into various languages, but actually the key problem to some of these communities is that while they can speak their native tongue, they cannot actually read it. So by translating resources into different languages, Gujarati and all that, it doesn't actually help, because the people you are targeting can't actually read their own language. And this is why we know that the Cancer Allies would work, because we'll get stakeholders in the room who understand the communities, who understand the challenges, and then we can work together to provide the solution. Next slide, please. So in terms of the planned activities for this last quarter, I've just kind of shown a brief, just a brief overview of the activities we've planned. We have started to, and will continue to work in partnership with local systems and charities to facilitate a series of workshops and to develop resources. And these are targeted resources, based on the principle of co-production. We are not preferring the solution here. We are actually asking the people in the community to work together to identify the issues and to come up with the solution. And the resources are aimed at raising awareness of cancer signs and symptoms. We are planning to have community-led events. So we are linking in with community leaders, pastors within these communities, imams within mosque, and respectable people within the community. One of the things we found out in the launch event was that word of mouth is very, very important, and it's even. And the phrase is that the messenger is as important as the message. That was the key theme that came through our launch event, that the messenger is as important as the message. So it's not about getting the right messages to people, but it's about using the right conduits to get messages. People that, people within the BAME communities who listen to, people who have, respect and good standing within this community. So we're going to be working with community leaders to actually identify events within the communities. In addition to this, as part of the ongoing campaign, the Help Us Help You campaign that Nana talked about earlier, which is generally to the Thames Valley population, on the back of that, we're going to be running a targeted campaign on prostate and lung cancer, but it's more targeted because we're developing resources with the communities. And so we're going to run a social media campaign. And this would include videos, posters, leaflets, banners, WhatsApp messages. We've heard that actually WhatsApp messages are quite powerful. You know how there's so many WhatsApp groups and messages have wider reach when you use WhatsApp messages, newsletters, articles, awareness, seminars, to mention but a few. Next slide, please. In terms of how you can support us with the Cancer Allies program, if you have links with community groups, within the BME, BAME, the Black, Asian, minority ethnic groups within Buckinghamshire, Oxfordshire, and Berkshire, Swindon, and Milton Keynes. If you have links to community groups with leaders within these communities, we would very much like for you to connect us. In addition to that, I'm sure in your field of work, I'm sure you might have come across best practices. You might actually have some good ideas in terms of what we can do with the Cancer Allies program. We are all up for ideas. So if there's any information that you can share with us, Gaina has shared our mailbox. We would very much love to hear from you. That's it from me. So I'll hand over to Lindell now to introduce the patient engagement. Thank you.
Hello, everyone. Welcome today. It's really lovely to see so many people on the call and supporting us with the patient and public engagement work. I'm Lyndall Moore. I'm the lead cancer nurse at the Thames Valley Cancer Alliance. And I am here to very strongly support our patients and the public with engaging in the work that we will be doing. And I would like to give my commitment to supporting people who may step forward to work with us to support you in working alongside our work streams and in the various projects, as I'll go through shortly. But what I do want to say is that Thames Valley Cancer Alliance, we do want to make sure that patient and carers are equal partners with us on our work and its support, that we can make a difference in the way that we actually deliver our cancer services, and by involving people affected by cancer to support the design of local service delivery helps us to better understand what matters most to patients. User involvement really does drive improvement and holds organisations to account, and it ensures that our services are based on what the local need is. I, as a clinician, might think that there's something that's required, but actually it's only with really talking to our patients that we understand what you believe are important elements of delivering that service. And it's so important that we have patients at the heart of our local cancer systems, and cancer alliances offer a vehicle for ensuring this happens across the country. So there's a variety of ways that you can get involved and a few opportunities that we can go through where you can share your experiences. This can be in the co-production and collaboration within project groups and to support the design and redesign of cancer pathways. You've heard a little bit about that this afternoon in the presentations from my colleagues at the Thames Valley Cancer Alliance. You could be a patient representative on one of our 17 tumour site-specific clinical advisory groups. So that's where within the Alliance, we would bring together key clinicians and patients to talk about the service delivery for that specific tumour group. So perhaps in the colorectal group, if I take that as an example, you'd have surgeons, oncologists coming together with clinical nurse specialists and patients to talk about the different elements of that cancer pathway, from early diagnosis work and screening work right through to diagnosis to living well and beyond with the personalised care that Hannah spoke about. You could also give feedback on documents and patient-facing information about what's important to patients. And so that's also could include feedback on our website and how we could make it more user-friendly and what would be of more interest to people accessing that site. You could also share your views on specific areas. So we would have for specific projects, perhaps smaller, more focused groups and surveys that we would be finding out information. You could step forward and support that work. We'll also be doing interviews to evaluate new services that they're implemented and providing that feedback is important. And then you could promote what we're doing with your friends and networks, all of the work that we're doing across the Alliance and how different people can get involved. And Abby gave a good example of how we're looking for people to help with Cancer Allies. And then we have different cancer events, education events and conferences. And again, we want to make sure that that patient voice is heard in all of those events. And by following us on Twitter and retweeting, I should say, our cancer awareness campaigns and messages, it's really helpful for making sure that all of our information that we're trying to share is getting out there across the Alliance and country. And it may also be helpful that you could actually provide us a little bit more feedback about what's a good program for induction for our new reps and what you think would be helpful information starting on that journey. Ultimately, what's important is it's up to you, the level of commitment, the time that you have to be involved. But we're here to help you with talking that through if you do have any questions about it. If I could go to the next slide, please. And then we're very fortunate today to have 3 patient representatives coming forward to talk about the work that they've been involved in. First off, I'd like to introduce Patrick Mcguire. He has been supporting us in the rapid diagnostic service work that we've been doing. And then following on from Patrick will be Jan Backhouse and Linda Wilson. But what I'd like to say is it's been fabulous to have Patrick as part of the RDS group. I've really appreciated his engagement and critical thinking about how we're working on our projects, and it provides that challenge back to the project group of how we're delivering on things. And so, you know, real personal thanks to Patrick for the work he's doing, but I'll let him explain a little bit more about what he's doing now. Thanks, Patrick.
Thanks very much, Lyndall. Thanks for those kind words. I got involved some years ago. My wife died from bowel cancer in March 2007 following a very late diagnosis. And as a result of that, I started fundraising and volunteering, particularly for Cancer Research UK. Over the years, there's been an increased interest in the development of patient and public involvement in a whole range of opportunities. Trying to put those people with an experience of cancer at the centre of future developments. And 3 years ago, I was fortunate to successfully apply for the post of patient and public involvement representative for the Thames Valley Cancer Alliance on the NHS Cancer Programme's Patient and Public Voices Forum, which is a national group that meets people affected by cancer from all across England to try to support and monitor the developments of the NHS within its national cancer programme. This has led to me being involved in a whole range of both fascinating and extremely worthwhile projects. Many of them we heard about earlier. So, for example, I'm on the national steering group for the development of the colon capsule endoscopy. Locally, as Lyndall and Gaynor spoke earlier about the rapid diagnostic service being developed in the Thames Valley Cancer Alliance, and that's something I feel particularly passionate about. But to have an involvement in the future development of that, an early diagnosis is going to make so much difference. Even if, according to the NHS's own figures, if we meet the target that we've set for improvements in early diagnosis, that's 55,000 lives per year saved. And that's the difference that I think we can make as volunteers. The volunteering, I think, that we do is about putting the patient at the heart of everything the NHS does. I think it shows the NHS commitment to better understand from those who have that lived experience of cancer what it's actually like to use their cancer services. Personally, the volunteering that I've done within the TVCA, I've found to be extremely interesting and also hugely rewarding. I've always felt welcomed. I've always been treated with respect. And my contributions, I felt, have always been valued. That's not to say everybody always agrees with every thought I have or everything I think ought to happen. But it does ensure that as volunteers, that our patient voice is heard as we volunteer alongside health professionals. And it helps to identify what matters most to patients and their families as we go down the road of developing future cancer services. I know many of you on the patient partnership group, the volunteers, have got a huge range of expertise and experience. But if you are new to it, as I was, I'd simply encourage you to simply bring along your lived experience of cancer to the projects you can get involved in, and be involved as much or as little as you want. I think every contribution is a valuable contribution. Don't worry about the lack of knowledge of the health system or services. I know I did, but I quickly found out that doesn't really matter. It's not what matters in this role. What mostly matters is your enthusiasm, your passion, your willingness to learn. And I've learned so much in the years that I've been volunteering as a patient carer. Not just what I've learned, but I've also, as a bonus, got to meet so many wonderful people along the way. And it's people who are so committed, so passionate about improving cancer outcomes. There's so many facts and figures around this field. We've seen today, this afternoon, so many interesting developments, so many facts, so many figures, so many statistics. But I think what drives me as a volunteer is the thought that behind each one of those statistics, behind each one of those facts, there is a real person, there is a real family. And I think, you know, many of us know that going through this experience is probably one of the most devastating things that we'll ever face. But I think the volunteering that we do can make such a difference. And for me, what really drives me, it gives me hope for the future. And I think it gives us all hope for the future when we see the commitment, the developments that are underway. I think as we volunteer, we feel, and I know I certainly do, and talking to other volunteers, you feel part of a much bigger team, a team of other patient public members, NHS staff, Cancer Alliance staff, all the health professionals involved. But I've learned that together we really do make a difference. I think, you know, it's difficult at times. It's an emotional journey, but it's a passionate journey. It's a committed journey. And I think we are transforming lives. And I think that ultimately what we are doing is improving cancer diagnoses, treatments and outcomes. It is a hugely rewarding piece of volunteering to do. I'm certainly looking forward to continuing volunteering with the Cancer Alliance. I'm looking forward to working alongside many of you, knowing that we really will make that difference and improve cancer outcomes. And I'm going to stop there and hand over now to Jan for her thoughts.
Hello everybody, my name's Jan Backhouse, and I'm a breast cancer survivor since 2002. And like many cancer patients, I was extremely grateful to have come out of the other side of treatment, and so I felt I would like to give back. I got involved in a breast cancer support group, and it made me realise that not everyone was as lucky as I had been in terms of outcome or quality of treatment. So when, in my capacity as group, the group leader, I was approached by a lady from the Thames Valley Cancer Network to be a patient rep in the breast group of medics. I joined, but not really knowing how I could be of use, because I don't have any expertise in medical things at all. And I'm not very eloquent, but anyway, they assured me that my patient experience would be very useful. And since then, I found that actually what we do is in the Thames Valley group that I'm involved in, the breast group, what we do is we give the medics the patient view of changes and introductions to any new services, or perhaps oversee pamphlets. Because the view of the medic, while it is professional, and as Patrick said, you know, they are very passionate, these people that are involved in these groups, their view is often very different to our own as a patient, because they're just looking at it from a medical point of view. We're able to help to get new services suggested by the medics to the attention of the purse holders, because that's really quite important. In both the hospital trust and the local CCGs. And we did that with the sentinel node biopsy locally. And that's something that saves breast cancer patients a great deal of discomfort. And it also means that ladies or gentlemen who have breast cancer had less invasive surgery and improved the recovery outcome. And obviously, as Patrick has mentioned, there's lots more beside that people can get involved in. And I also sit on the Bucks and the Oxford Hospital Trust and CCG. And for me, that, you know, to be able to give the patient view, and it is, as Patrick mentioned earlier, it's very much valued, although they don't always take on board what you're suggesting, but at least you're listened to and respected. What I would say to you, you know, please get involved, because you are the link needed to ensure that the NHS mantra, no decision about me without me, is maintained. The only way it can happen. Thank you. I'll pass across now to Linda, who'll tell you a little bit more about other experiences that you can get involved in the patient representation group. Thank you.
Hello, everyone. I'm Linda Wilson, a breast cancer patient rep from Milton Keynes. I had breast cancer 23 years ago, this September, and although before I had cancer of any sort, I'd thought about it at times, you know, it was something I wouldn't have wanted to have. And I learned when I was diagnosed with it that actually having it and coming through treatment gives you an entirely different outlook on it, because it becomes personal. You understand the implications of being the patient, of facing what might be your future in a way which you can't possibly appreciate except in a rather intellectual way until it happens to you. So in that respect, we are an asset to the health service, because we do see it differently. Whatever you think about what you might know about the medical side of things, we do know what it feels like to face up to having cancer. And my mother-in-law actually got breast cancer after me and died, and my husband and I cared for her, so I saw how it was from her point of view too. And I think all of this helps us to know that treatment isn't just about making you physically well again, it's what it feels like to go through the process of being treated, the sort of premises you might be treated in, the facilities, what might be said to you, the sort of information you get. And belonging to any group where you can exchange ideas with the health professionals means that some of what we are aware of can be shared and taken on board. And I have to say that in the 23 years since I was diagnosed, going through breast cancer as a patient has changed beyond recognition. Changes to what happens may be minusculely slow. Possibly you don't think anything's happening, but as years pass, you do see that the things that patients have said were important and what would have made them feel better happen. So soon after I had breast cancer, I joined a breast cancer support group with some pals in Milton Keynes, so I could see what happened to other ladies. I've belonged all the time since then and can see what concerns present patients have. There's a cancer patient partnership at Milton Keynes where we, members from different cancer support groups and health interests in Milton Keynes, meet together with the cancer team at Milton Keynes and talk about what might help. And things come up. We talk about bus services and changing rooms, and we now have a wonderful cancer centre. You know, things do change as people talk about what would be better for them. I've belonged to the CAG along with Jan for quite a long time, and as she says, our views are listened to. We can take back what's happening elsewhere and make a difference and ensure that services are more equivalent across the Alliance, all of which I think is useful and what people would value. So I say patients have a unique insight into what it feels like, what's needed, and we should, if we can, get involved and put our views forward. I have to say one of my pet hobby horses is information and how accessible and understandable it is. Websites, whether they actually tell people what they want to know. All these things are valid causes, all things we can talk about and feed back and hopefully improve things. So I think The best thing one can do to make something positive come out of one's cancer experience is get involved. And that's it. Thank you.
Linda, thank you ever so much, and to Patrick and Jan also for sharing obviously your involvement with the Alliance today, and obviously how we're learning from your experiences and listening to obviously those that you're closely working with as well, with clinicians or other patients from your support groups. Next slide, please. So we're aware that there's a growing recognition of the value that patient voice can bring to support improvements to patient safety, patient experience within the health services, as touched upon our patient representatives earlier. As Abby mentioned, patient engagement and public involvement is a key enabler across the Alliance's defined 4 priorities for 21 and 22. Over the last year, the number of patient carer representatives wishing to support the Alliance has steadily grown, which I'm absolutely thrilled about. But it's essential that the patient engagement is meaningful and has impact in the work that we're doing. With the creation of the Thames Valley Cancer Alliance Patient Partnership Group, we hope that we can draw together the views from a broad range of perspectives and expertise from our patients, carers and representatives from health and social care organisations, all working together in partnership to help influence, change and improve services to meet the needs of our local population. Membership of the group will incorporate individuals with a lived experience of cancer, as well as representatives from a number of our wider stakeholder organisations. The group will be the mechanism for drawing in and discussing feedback from patients and public alike, as well as provide project updates and shared learning from our patient carer involvement. This information will then be fed into our Thames Valley Cancer Alliance Executive Board, where leaders will come together from different hospital trusts, primary care, other health and social care organisations, working together to co-design and improve cancer services within our geography. The board is responsible for ensuring that the patient voice is represented as an equal partner and is at the heart of all of our discussions. They also should have the same oversight of the strategic development and implementation phases as the other organisations on our executive board. A draft terms of reference for this group has been co-developed with some of our patient representatives. It sets out further details around the membership, its remit, responsibilities and reporting arrangement of the PPG. After the meeting, we would very much like to share it with those on the call for comment. Your feedback would be greatly welcomed. It's our intention that the PPG will meet quarterly ahead of the quarterly executive board meetings. This will enable feedback from the meeting to then be shared at board level and likewise be a feed out mechanism back to the PPG for the next meeting. We're looking to arrange our next PPG meeting in December ahead of the executive board meeting in January. Next slide, please, Nat. So within the terms of reference drafted, we've stated that we're keen that the chair of the patient partnership group is also the overall patient voice represented on our executive board. As well as giving strategic and accountable leadership to the PPG, they'll be instrumental in ensuring that the opinions and any feedback shared by group members is fed into the board as part of their role responsibilities. An advert and further information about the role has been disseminated through internal and external stakeholders, promoting this recruitment campaign, including through all of our known patient support groups and representatives as well. A communication toolkit was also shared far and wide to help further promotion through social media, newsletter, bulletins, Twitter, etc. The board role should be held by someone who has a personal experience of cancer treatment and care, either as a patient or as a carer of someone affected by the disease, ideally within the last 5 years. As a senior partner on the executive board, we're hoping that this person would ideally have an informed awareness of the NHS long-term plan, a passion to improve cancer services, have had previous and or current experience of representing patient and public voice in public life and all on regional healthcare forums, and a willingness to challenge and provide an impartial approach to ensure all perspectives and experiences of patients are considered and that they keep the patient voice as a fundamental guiding principle to this. An involvement payment is being offered in line with NHS patient and public involvement policy for this dual role, and the dual role obviously being the chair of the PPG and overall patient voice on our executive board. A full role description is hosted on our website, as well as the associated application forms which are available to download for anyone interested. Applications should be submitted via email by the 17th of September, either to myself or to our general mailbox with the team, and interviews will then be held in October. It would be greatly appreciated of those on the call if you could please publicise this recruitment campaign again through your local networks. And when we share the slide deck, there'll be a link onto our website if those new to the group haven't yet discovered the website to review. So having given an overview of our Alliance's activities, I'd like to hand back to Lyndall to open the floor for any questions about what's been presented so far. Thank you, Lyndall.
Thank you, Lisa. We've shared a lot of information with people today, and I'm sure it's probably stimulated quite a bit of thought, and you probably have some questions you'd like to ask. I'm just quickly having a look through the meeting chat, and I think most questions have been answered. And I think if you do have any queries there, do go to the email addresses of the team as they've asked. There is just one question, Hannah, I wonder if you'd like to answer. It's about, is everyone eligible for personalised care? Was one of the questions there. Otherwise, I'll sort of respond if you like.
Yeah, thanks, Lyndall. Yeah. So yes, so in short answer, yes, everyone with a diagnosis of cancer is eligible for personalised care. At the moment, we do have varying rates across the patch of what's being offered. So some of our hospital trusts are really, really good at offering the health and wellbeing stuff. But the nursing team perhaps don't quite have the capacity to offer as many holistic needs assessments as we would like, and vice versa. We have other hospitals that are really doing brilliant stuff with the holistic needs assessments, but perhaps haven't quite, got the same capacity to offer health and wellbeing. So one of the key things we're looking at the moment is equity across the patch to ensure that all patients receive the same offer. But yes, everyone has the option to receive personalised care and should be offered it by their team. But as I say, we're working with the teams at the moment. We're seeing perhaps where that might mean that either some of the staff need maybe a little bit more training, or it may be that we need additional staff members in that team. As with all things, as with all of the NHS, everyone is working extremely hard. So we're looking to see how we can support and ensure that that's equitable for everyone.
Great, thanks, Hannah. There's just another question I think you might be well placed to answer. It talks about what about those who can't do virtual sessions? I think that was talking about your health and wellbeing events.
Yeah, absolutely. Yes, thanks. I think it was Nicholas that asked that question. Great question there. So yeah, the virtual health and wellbeing events are one offer, and they sit alongside the offer that the hospital trusts have for face-to-face sessions. So we're very aware that we're not replacing an offer that the hospital would normally give in terms of face-to-face sessions. The other thing that we are looking at doing as well is having the content being recorded and uploaded onto probably our website or accessed through our website. So it may be that either if somebody can't access the virtual sessions because of timing, for example, then the content would still be available. But equally, we are very conscious of people who perhaps don't like to use technology. Some of you, like myself, I'm very sociable. I'd much rather go to a face-to-face session and meet people than I would, whilst this is wonderful and it's been great throughout COVID. So, it's absolutely not replacing that face-to-face offer. It sits alongside it.
I can see Nicholas has put his hand up. Nicholas, do you want to come in there?
Yeah, just a quick one. Thanks for that. That was useful, and yeah, very thought-provoking and really interesting, really great initiative. So I'm glad I attended. Just a quick one around campaigns and the inequalities of health. Healthwatch Woking became really aware during the pandemic from the learning disabled community about the lack of easy read information and how that hugely disadvantaged them. So in terms of the campaign, I'd be really keen to see easy read documentation so that the learning disabled community get the same benefit as the rest of us in terms of understanding and being informed.
I think that's a great thing that you've raised, Nicholas. I hope you don't mind me using your first name. It is something that we as an alliance will certainly be taking forward, and I know many of the trusts already look at how they have easy read leaflets for cancer information. But actually, perhaps are you volunteering to help us with that, or people within your community? Because I think it'd be great to have a strong link with trying to do some service improvement work, looking at learning disability needs within the Alliance.
Well, I can certainly, as a starting point, link you into the local learning disability adult group as a starting point, and you can take it from there. Brilliant,
thank you. There's also some other questions, Hannah, that you might be able to help us with. You're popular this afternoon. There's a question about when the quality of life survey will be available. The results, I should say. Sorry.
Yeah, sorry, just unmuting myself there. So the first lot of results that we're hoping to see should be available around October time. So the Quality of Life survey was launched in December 2020 for patients who were diagnosed with prostate, colorectal and breast cancer. It is currently, any day now, going to be rolled out to a majority of other patients. There are a few exceptions to the rule. So for example, there are some types of skin cancer where, you know, patients would have maybe just had something like a mole removed who won't be sent a quality of life survey. But yeah, for everyone else, the survey should be going out, yeah, as I say, anytime now, and that's for patients 18 months after their diagnosis. And we actually are going to be putting together some more communications about that so that all of our support groups will be aware that that's coming out, and to, you know, so that you can let your members know if you're part of the support group. But yeah, as I say, the first lot of results that we're expecting to see is around October. There will be a website with those results on, and they will be publicly available data as well. And from an alliance perspective, obviously, as soon as those results come in, we'll be having a conversation to have a look to see, is there anything that we could be, you know, doing off the back of those results to inform future work and support for patients?
And then there's another question from Vicky Randall saying, are you putting together a range of events so that other groups are not overlapping, or are you going to offer partner sessions through other organisations?
I'm presuming, Vicky, that was relating to the virtual health and wellbeing sessions. So if so, Natalie is our project manager for this particular project, and one of the things that she's doing at the moment is a timeline of what each of the current hospital trusts are offering and how we link in with that. There possibly will be a little bit of an overlap with the sessions that Royal Berkshire are offering, and that's because they do a 6-month programme, which is, and because their model has been so successful, and we're looking to basically copy it, in want for a better word. So yeah, I think because of that we are going to have a slight overlap with Royal Berkshire, and our speakers are going to be from each of the different hospital community settings. So we'll have a range of speakers from across the patch, from different trusts and community services. So that way we're hoping that we'll be linked in with everyone through that. Hopefully, Vicky, that answers the question.
Thanks.
And then the next one is about holistic needs analysis. Are there set timeframes after diagnosis and treatment as to when H&As are done? To help Hannah, I'll step in and say, yes, there are. Generally speaking, it's done within 6 weeks of diagnosis, if possible, at this the initial health needs assessment. And then usually after you've completed treatment, so if you've had surgery and perhaps chemotherapy, it would come sort of after that time, approximately 6 months or so down the line. Is there anything else to add there, Hannah?
Yeah, I was going to say, I think as you mentioned there, Lyndall, it's kind of, we have rough timeframes, but they're not targets as such, in the sense that, you know, it will depend on every tumour site and when's most appropriate for those patients. So as Linda was saying, we have kind of rough time points which we think for majority of patients will work, but that may differ depending on someone's diagnosis and treatment plan, etc.
Great.
Thanks, Linda.
And then there's a question, I think, for Mark about GP PCN toolkit. Was this sent to the group?
Yeah, hi Linda. I'm not sure if it was, but it's readily available. It's on our website, and also when we send the slides out, quite happy to send the link to the toolkit as well.
Brilliant. Thank you, Mark. That's helpful. And great, Judy. Thank you very much for your update about the LD work you've done in Bucks. That's great to hear. I'll look forward to hearing a bit more about that from you. I'm sure there's other questions. Okay, thank you, Vicky, for further comments, particularly from the new people that have joined today, to hear a little bit more about the role of being involved in our various groups. Do you have any questions to some of the sort of more longer standing members of the group who have been patient reps for a little while that you would like to ask them? We have a wealth of experience. It was really helpful, I thought, listening to Patrick, Jan, and Linda today on the good work that they've been doing. Does put your hand up if there's a question at all for some of the longer standing members. Otherwise, from the wider groups that are present, are there any questions at all that you'd like to put to any of the patient reps or to the Alliance themselves? Ian, I can see your hand. Thanks for putting your hand up.
Good afternoon. Sorry I joined the meeting a bit late, got a little bit sidetracked along the way. First off, thank you to everybody for taking the time out this afternoon. And I apologise if this part has already been mentioned previously. Is there not a way, with all the waiting rooms around all the various hospitals, GP practices, to put some more cancer awareness notes up? Shall we say, I know I'm based in Oxford or Oxfordshire, and the Churchill is my hospital, and Maggie's is our local centre. Whenever I've been to Maggie's, I don't really see a huge amount of people going through the centre compared to the amount of cancer patients that there are in Oxfordshire. Is there not a way of encouraging people to go to Maggie's or to seek outside help by putting up notices within the GP surgeries, etc., to let more people be aware of the facilities and the support that's actually out there for them? I know that if you're in the waiting room at the Churchill in haematology, they've got various TV screens around saying, oh, the appointments are running a little bit late, etc. Is there not another way of adding to the information that's given out, and maybe to your GP practices that have all got screens in their surgeries now that are all linked up via internet, Wi-Fi, whatever, that actually more support could be put up on those screens just as a rolling message?
So Linda, is it possible just to share some thoughts on Ian's comment there? Thank you, Ian. We actually have Claire Marriott on the call, who sort of runs and looks after the Maggie Centre. So she may be in a better position to obviously share who she currently is linked in with regards to promotion. I do know, however, that our primary care colleagues they do run sort of cancer awareness campaigns on their reception televisions, so that when patients are waiting for their appointments to see the GP, there's obviously a visual awareness there of the cancer awareness messages, rather than just maybe a pile of leaflets in the corner or a notice board leaflet that maybe nobody sort of really takes any sort of point of seeing when they're obviously waiting for their GP. Claire, if you're on the call, do you want to add anything more to Ian's question or query?
Yeah.
Thanks, Ian, and thanks, Lisa. We do spend a lot of time sending leaflets out all around the place and going around the hospital, putting them up around the place. But it's yeah, it's quite hard to just keep them current because, as you're saying, kind of leaflets get moved, posters get covered. We have tried before to get some information on the moving screens, and that's something we're still trying to do. So, any help or ideas about how to make that happen, welcome. But yeah, we keep trying, but there's a lot of information for people to see, and we're only just part of the information people become aware. So.
Thank you, everyone, for comments there. I think we could take that away and perhaps think about how we can sort of share those messages more widely. Thanks for raising it. So we've got some others that have raised their hand. Peter, I think you were next. If you'd like to ask your question, please.
Yes, thank you. Peter Glass, 11 years high-risk patient, prostate cancer at the Royal Berkshire Hospital. Very interested in hearing from Dr. Anant, Bracknell GP, who I notice has got some excellent things to say. Delighted to see he's a member of the TVCA. I noticed the rapid advance in the breathtaking speed of development of IT communication between cancer clinicians in the hospital and GPs and patients. Very breathtaking speed of advance. And I think I would all power to people like Anant who are prepared to speak up for GPs in their key role in improving the patient experience. So thank you. It's more an observation than a question.
Thank you very much, Peter. Ian.
Yes, good afternoon. Thanks for a very interesting session. I was actually just picking up on other Ian's point and Claire's point. I think that it was mentioned earlier in the session that word of mouth is critical in disseminating information, across various potential user groups. And I'm a huge advocate for that. I think one of the things that have worked very well in my experience is engaging the specialist clinical team who talk to patients day in, day out, and can mention the support groups available to sufferers of particular types of cancer, and indeed wider support across the NHS and ancillary bodies. So I do think, word of mouth, particularly if you trust somebody, I think is a very, very, very powerful tool for disseminating information.
Great, thank you very much for your comments. Are there any other questions or comments that people would like to make? I'm just aware of time, that we're coming close to the end. Nikki.
Sorry, just going back to the difficulty with getting information onto screens in waiting rooms. It's sort of reassuring that everyone's having the same issues as I'd had over many years. And I think maybe the patients might have more impact on the various people that control that information. That patient voice could maybe have more of an impact. And I know that patients would value having that information just from what we've heard today. And all of the different organisations, of course, Claire at Maggie's, Michelle at Hummingbird, we've all made some really, really good films and things. And none of it's ever seen the light of day. So, well, that's not true. It's got onto other places and other platforms, which aren't quite so easy to find. But it would be great if patients could have some sort of impact on that.
Great, thank you again for your comments. We will take away that message around the TV screens and look at what we can do around that communication to support that. Well, I'd just like to say thank you to you all very much for your contributions this afternoon, for supporting our launch event for the Patient Partnership Group. This is really just the beginning of our journey of trying to work together with you all to improve patient services, to make sure that the patient is at the absolute heart of everything that we do, and that we are going along the right path when we're trying to redesign our services, that they meet patient and carer needs along the way. So your voice is really strong, it is really powerful. We do want to hear from you, and we would really like to have you all engage in our work as we go forward. And as the patients reps had commented on, it's up to you as to how much you feel that you could give with your time and be involved in the various sessions, whether you do want to be involved in some of the like RDS sort of project work, the clinical advisory groups, or to other bits about providing information on our patient leaflets and social media work that we're doing. Whatever it is, we'd really love to hear from you. Lisa has done some extraordinary work and is here to support a lot of this going forward. I know you all have her contact details. She's very keen for you to come forward and to talk about how we can work together moving forward. So please don't hesitate to contact us to take things forward. Following the meeting, we will share the presentation as has been requested. We'll share the terms of reference for the patient partnership group going forward. And there's also the links to the chair of that patient partnership group and the board position that we would really like to hear from people, or for you to share it as far and wide as possible, so we have some good interest in that. If you have any other questions, please don't hesitate to come forward with Lisa and myself. We're here to help and to hear your thoughts. And please keep in contact. Lisa, is there anything else that you would like to share from today?
I don't think so. On the last slide is our generic contact details for the Alliance, for those people that haven't contacted us directly from it. Obviously, that's my email address as well. And I'm happy to have a telephone conversation with anybody also who would like to know more about the Alliance involvement, or sort of linking us up with external stakeholders accordingly. So by all means, please feel free to get in touch.
And then I'd just like to say a huge thank you to Lisa herself. She's worked extraordinarily hard to bring this all together, and to my Thames Valley colleagues for coming along this afternoon and sharing the work they're doing. They've done a great work bringing this together. I must say, I've been on annual leave and only returned today. So Lisa has been extraordinary with putting this together. So thank you very much, Lisa, for what you've done today. Thank you all very much for attending. We really have appreciated this afternoon. It's been great to hear some of your thoughts, and we look forward to working with you going forward.
Thanks, everyone. Take care. Stay safe.
Bye.